So yeah, whoop, whoop, we made it to the end of the year. That was not without some sickness, and I apologize tonight. I do have a bit of a raspy throat right now. But anyway, yeah. So my name is Chandler. I'm a pulmonary disease navigator and a respiratory educator. And I liked going over neonates and pediatrics when I was in school. I thought the science behind embryology specifically was very, very interesting. But we see it with the adult population as well. Extubations and self-extubations, things like that, or accidental extubations. We look at airway management in terms of the neonate and pediatrics, and sometimes, especially for adult RT by trade, really, we run across these neonates sometimes in the ER and stuff like that, and we're like, oh, all right, wait a minute, what are we working with here, right? So I always say it's one thing to need an airway and another to manage one, right? Just as we learned in pathology, neonatal airways are somewhat different than the adult. Much so is different in terms of the whole neonate, but the reason some of these patients may need them can vary as well. I was taught to always think facilitate, and protect when we're thinking of any type of intubation or something like that. So we want to be able to facilitate mechanical ventilation. We want to be able to facilitate suctioning, protect from aspiration, and protect the airway in general. With that, we'll kind of dive in with our objectives. So we'll very briefly review the normal neonatal airway, kind of as it relates to the adult airway as well. We'll look at OPAs, NPAs, and laryngeal masks, and insertion of these airways. I do have a few videos, but we may be under some time constraint with those. But I'll ask you guys a question. You don't have to answer or anything like that. Just to kind of make this a bit of a semantic situation where we can apply it to real world things. We'll look at ET tubes and intubation, the equipment, different types of bags we may use. I'll ask you a few more questions about that. We'll look at suctioning, pretty decent review on that. We'll look at VAP considerations, tracheostomies and their mysteriousness. You guys can't see me, but I'm sprinkling, special dust on there, and their mysteriousness. I worked with a lot of trachs. I think trachs are super duper, and we'll try to shine some light on those. We'll look at extubation planned and I should say unplanned, not unplanned, but. So let's kind of look at this neonatal airway here. And this is really about the best graphic I could find for comparison. So you can kind of look through that as I'm going through this. So there are many different ways the neonate's airway differs from an adult. So we know, or we should know, at least that the tongue in proportion to the rest of the oral pharynx is quite large and can present to be a problem with intubation. We're looking at malapodies and things like that. But also, we can keep this in the back of our mind when we're thinking of our neonates and things like that. With sleep apnea or any type of blockage, we know that tongue is going to be a definite problem, or could be a definite problem, rather. The epiglottis, the neonates have a narrow epiglottis that is angled above the glottis. So in this is a little more parallel in adults, and we can see that with number 2 there. It's just sitting at a different angle. We can see how maybe the differentiation between using a Macintosh versus a Miller may be indicated here. Look at the molecular space as well. The cricoid is more narrow. In adults, the glottis is the most narrow. The larynx is more superior, and this is kind of where we get the more anterior larynx. So folks say, neonates have a more anterior larynx. This is kind of where we see this. In the adult, it lays at about C4, C5. whereas in neonates, very young infants, he lays around a C3 and C4, talking about our cervical spine. So we can see how all of this may, if you're sitting there, maybe you're one of the RTs that intubate in your facility and a child rolls through or something, you're thinking, wait a minute, I know there's something different about this. Well, this is how you can see, and this is how you can see maybe how it could present to be a problem as well. Pharyngeal airways, we'll look at OPAs and MPAs. So indication for an oropharyngeal airway, we want to facilitate bag mass ventilation and oral suctioning. Some of those devices, and some don't, but some of those devices actually have a channel or a groove in the side of it that's supposed to help facilitate suctioning. My thing is, if you've got a Yonkauer there, you probably just about get it. It can be used as a bite block with an ET tube or during seizures. It does support the base of the tongue. So I know in my time in the units that you get that patient every now and then that's about to pretty much eat through their ET tube. Your peak pressures are insane. You can't get any return back, and so on and so on. I won't say that so much for the neonates, but pediatrics for sure. Neonates, the tube is quite malleable, but I'd say we could definitely still have some blockage. But yeah, we can use OPAs bite block, and of course during seizures. We want to use this with the unconscious patient. We'll see why that might be. If some of y'all know, don't say it out loud, right? We'll look at indications for nasopharyngeal airways. These can be used for conscious and older patients, and a lot of the times, for me anyway, we would drop a trumpet. Excuse me. We drop a trumpet. Let's say if we have somebody on BiPAP that's requiring, you say Q2 NT suction, we'll go ahead and drop a trumpet down and well, I'll tell you why in just a little while while we do that. So yeah, it can be used for conscious patients. It supports the base of the tongue, facilitate nasal tracheal suction, and decrease the trauma of NT suction. And now, folks, I know we've all done some NT suctioning more than likely, and it can be a lot of damage done if you're not very careful. You kind of finesse it, right? Use in newborns with Pierre-Robin syndrome, or Pierre-Robin syndrome, and we can use it with pharyngeal swelling. The thing about the NPA, for me anyway, I always like it as an adjunct, because as long as I know the tongue is being supported, it's properly sized and patent, then I've more than likely got a decent airway. Now with the OPAs, yeah, sure, but we'll kind of see how that could be a problem too. So we look at the complications of an OPA. So these devices should be left unsecured. So we're putting should be appropriately sized, but a decent sized chunk of plastic or rubber or whatever kind you got into a patient's mouth, an unconscious patient's mouth. And we don't want to strap it down. These devices should be left unsecure, which possesses a threat to unintentional movement and removal. Removal in the case of seizures, or you get a patient biting the tube, so on and so forth. Sure, that may present to be a problem because it would be hard to get back in. But for your unconscious patient, it should be pretty easy to get back in. So if the patient gags, we stimulate the gag reflex, then remove it and perform suction if you need to, give them some O's or what have you. This is a big thing with OPAs, because if we do have, let's say we have a semi comatose patient, maybe somebody's very lethargic, and at first maybe we think they're unconscious, they need an OPA, whatever, and they start vomiting, that's you got aspiration right then and there, right? It can cause a ringospasm, and if improperly sized, we'll cover that on the next slide. But yeah, I mean, you kind of think of if it was improperly sized. Think about that. It'll probably make sense in just a minute. Complications of an MPA. The most common is trauma. We know that the nose is composed of very vascular system. I always tell people if I flick you in the nose, flick somebody hard enough in the nose, they'll start bleeding, right? So if we're putting, one thing to put say a 12 French, 14 French catheter, whatever you got, and NT suction somebody, right? It's another thing to take that big old MPA into somebody's nose, right? So the most common complications, trauma. And the biggest way to try to mitigate this is to use as much lube as you can, water-soluble lube, right? Due to the high vascularity of the nose, epistaxis is common as well. We would change the MPA at least once a day, depending on the severity of the patient. And that's kind of the thing too. Of course, you're going to use your clinical thinking, but if you're having to use MPAs with patients, they're likely pretty sick. So assess your situation when you're moving in. And sometimes, you can remove that MPA and it'd be kind of hard to get back in too. And we'll look at improper sizing. So sizing the OPA, if the OPA is too small, then there's a chance for oral tissue displacement, right? That can cause further obstruction. And now you will think of the neonates, right? The case may be that it's likely the OPA is too big, right? If it's too small, then we're presenting. It's a foreign object, right? Could be aspirated in some sense, or if anything, it could cause with the neonates. It could cause oral trauma. If it's too large, well, I mean, it's like I'm sure we've all seen the OPAs here. Imagine that could be an obstruction in and of itself, right? So we'll measure from the angle of the jaw to the corner of the mouth. Again, if we do have a few extra minutes, we'll try to play this video, but we'll measure from the angle of the jaw to the corner of the mouth when we're trying to size up our OPAs. Sizing up on our MPAs, this airway will not be effective if it's too small, right? Like I said, if you placed it in there, that's a pretty long airway or adjunct airway. And it's just like picking too small of an ET tube, right? You're going to have to overcome all of this resistance to deliver the breath and all of these things. So if it's too small, it's just not going to be effective. And if it's too big, it's going to become an obstruction. As we follow the nasopharyngeal airway through the oropharynx, laryngopharynx, all those things, we can see how placing an MPA if it was too long, could just be an obstruction as well. So for this, we'll measure from the earlobe to the tip of the nose. And, just kind of like picking your suction catheter for, your ET tube, think of the diameter of the nair itself, right? And keep in mind too, conal atresia and septal deviation and things like that as well. So let's just kind of apply it a little bit. So we asked the question, a patient is brought into the emergency room with a Glasgow Coma scale or Glasgow Coma score 3. So, I was taught less than 8 intubate, pretty much less than 3, it's coma, right? The patient does not respond to oral suctioning and does not have an intact pharyngeal reflex. There is no one present that can clinically place an endotracheal tube. Which easily usable adjunct airway listed could be used to facilitate ventilation? Carlin tube, you can pretty much just mark that one out, right? If they can't place an ET tube, they're not going to be able to place a trach or a Carlin's tube. So we look at MPAs and OPAs, right? So we want to facilitate bag mask ventilation, right? We use an MPA, sure, but this is an unconscious patient. Maybe they don't need all that extra trauma. You say, okay, I can place this MPA, bag them, and that should be good. So we place an OPA. in this instance, and kind of your giveaway there is the level of consciousness. We'll look at laryngeal masks. I know that when I think end of the first year of COVID, we started as an adjunct of intubation, we would place eye gels. But these LMAs they're pretty great as well. These devices are indicated for short-term ventilation, so you'll see it a lot in the OR. Well, I won't say a lot. Those anesthesiologists and CRNAs, they'll pop an ET tube out of their pocket and have the patient intubated before you know anything else. So short-term ventilation, you should use an LMA for sure, such as during surgery. If they have a difficult intubation or some kind of weird, anatomy down there, high malapati, what have you, LMA could be very, very useful. Let's say, they get picked up on the road or at home, maybe it's accidental overdose, and nobody's there skilled in intubation. They can place an LMA. I would much rather place an LMA versus a King or what's that other one? I forget. But those big, huge, or combi tube, those big, huge tubes, I would much rather than place a LMA than to blindly insert one of those. So we can use this when nobody is present that's skilled in intubation. There's a really cool thing about the LMAs, though. Some of the LMAs, which makes intubation easier. So it doesn't require a laryngoscope. You can kind of just, way I was taught for EMTs, you grab the tongue, pull the jaw, but you can do a jaw thrust and place the LMA that way. So it's placed in the pharynx superior to the epiglottis. So we know that the esophagus lays posterior to the trachea. So essentially the way we're going to do this is the tip of this. Let me get my pen. Give me a better picture of this at some point. So this part here is going to sit and block off the esophagus. So if we block off the esophagus, all of this here has sealed off effectively the upper airway, right? All we have left is one port, and we think of, the law of diffusion, things from high gradients, low gradients, and volumes and pressures. We only have one opening, right? So we exert a greater pressure here, and then it goes here. Well, where's it going to go? It's going to go through the trachea. If this is the esophagus, then this has to be the trachea lying superior. So these are an excellent adjunct to intubation. And a lot of these will come with their own syringe. It'll tell you exactly how much air should be used for whatever type of device that's going to be used. For neonates, they're quite small. But I mean, just like with everything else, we look at 0.5 to 1 for the neonates and 2 to 3 for children, or the child age population. And any one of these that I've ever used comes with its own syringe and filling instruction. The ET tube can be inserted through the intralumen, and I think that is one of the coolest things about it. Really, we've got our opening here. Now you would think this should be a 15 mil adapter. But some of these you can pass an ET tube through it and intubate the patient, because if this is the only opening that we have right here, and we put anything down into that airway, where is it going to go? It's going to go hopefully it's going to go into the trachea, right? And of course, you could drop a fiber optic through here, or do a small little bronch and pass your ET tube over it. Just to verify. Again, cuff volumes included with the specific element. We'll move on to intubation. So we'll look at the appropriate blade size, tube size, and so on. So the appropriate blade size, well, we'll kind of go over that in just a minute. We'll look at the Miller and McIntosh. So the Miller should roughly, when we're doing our intubation, should be at the level of the arytenoid cartilage. Essentially, it's going to kind of pinch that um, um, epiglottis, get it up and out of the way, whereas the McIntosh is going to fit into the follicular area and kind of lift the epiglottis, I would say, kind of secondarily. We use stylets. The stylets for neonates kind of remind me of bread ties. They're so thin. We use the appropriate tube size, of course. I was always taught, and I've always practiced, you get one size smaller, one size bigger than the one you're expecting to use. Of course, you have the one you're expecting to use, one size smaller and one size bigger. Check the cuff before, if it is cuffed, and we'll see later that generally over about 8 years old, they'll try to use uncuffed ET tubes. Bag valve masks. So we'll look at self-inflating, flow inflating, and we'll cover that a little more in depth in just a minute. Laryngoscopes. So I don't really know. I'm very right hand dominant. So always hold the laryngoscope with your left hand, but if you're left-handed, do use the right hand? I don't know. I don't know if there's a caveat to that or what. But as I was taught, and as I've always been told, always hold the laryngoscope with your left hand. And of course, we can use fiber optic or video laryngoscopes to increase accuracy, time in the airway, all that. It's kind of a standard of practice anymore. You have your old school docs that are like, give me a 4 Miller, and they'll they'll intubate with that regular. But majority of the time we've always, I'll say always, but majority of the time we've used fiber optic or video laryngoscopes via portable or the big screen that you drag in. Neonates generally uncuffed, and they have a vocal cord line or a black line. You can kind of see this here. Some of them will just have the black line, and of course, some of them will kind of look like this. They'll say pass the black line through and you should be good, and others will say kind of set it in between these two lines here. I need another picture of the double lined, but that's kind of your marking. That's how you know I should be in the airway. I shouldn't be right main stem or anything like that. So throughout the lecture here, we'll kind of see some of these little shortcuts, and that's exactly what they are. They're just shortcuts. So of course, if you're working with these neonates in the pediatrics, it's very, very, very vulnerable population. Sure, that'll be a good starting point, but always confirm your equation or confirm your tube size and all those things. So tube size and blade size. So weight based. So less than 1,000 grams or less than 28 weeks, we'll use a 2.5 with a Miller of 00. And we can see, so less than 1,000, 00, greater than 3, we're going to use a Miller 1, for instance. Pick your blade based off however you best intubate, things like that. Miller blade is pretty, I won't say standard, pretty common with neonates, however. And that goes up from a tube size of 2.5 to 4. So what about our tube length estimation? So, we can do damage with right main stem intubation. Well, imagine how fragile the lungs of a neonate are. And, say if you have stylet still in there and it's more rigid than without, then you could definitely do some major damage if you're not careful with your depth or your length. So we'll look at length estimation as the ET tube size times 3. And that's a good starting point. Like I said, if you're taking an MPS exam or something, that is great. You'll probably get your answer by that. But if you're going to place that ET tube, make sure you are accurate. Make sure, if you're really judging that. So we'll look at the mask, or yeah, the bag valve mask. We'll look at self-inflating versus flow inflating. So with the kiddos, flow inflating is to me is just the way to go. Self-inflating, sure, old reliable, right? But there are some perks and things like that for each and every one of them. And that's kind of what we're going to go over and why we may particularly use a flow inflating instead of a self. Don't get that. I'll confuse myself going from self and flow, so don't get confused. So we'll start with self. We'll look at self-inflating bags. So they're easier to use. This is what most of us are pretty used to using, especially with the adult population. Just rip it off the code card or whatever, and ain't got to worry about much else. Hook it up to some oxygen. Can use it with room air. I had a doctor one time. I had to switch flow meters or something like that, and the doctor was bagging, if you can believe it. And he said, "Oh wow, we're bagging with room air." Like, all right, but he's like, "Give me a 0.2 seconds." But you can use it with room air. The bag is always going to refill. If I'm not mistaken, it's around 600-700 mils per tidal volume. I guess depending on the bag, or that's the adult bag. 60. So that's the thing with the self-inflating too. Unless you've got a reservoir or something like that, the max that you're probably going to get, and this is with like perfect technique, perfect seal, all of that good stuff. 60 to 80% FiO2. They say, give me 100% O2. I give you about 80 is best I can do. But with this, it's a little harder to feel lung compliance. I'm sure we can all attest that after we get a patient intubated, one of your RT buddies or the doc will say, are they hard to bag? Is it easy to bag them? Maybe we've got some alveolar hemorrhage or something like that. It's going to start to cause some kind of back pressure. So with the self-inflating, it's kind of harder to feel that, which of course, if you do it a gajillion times, but let's look at those little neonate bags at that we're not going to feel much resistance or elastance with that. It's kind of a harder type of plastic most of the time, any that I've used. And it is hard to feel the return back onto that bag. So we'll move to the flow inflating. They're not as user-friendly. I know when I first kind of ran across the flow inflating, I was like, well, what is this whole little gadget here? But we're RTs, so this gadgets are a thing. Thing is, it can't be used without free-flowing oxygen and deflates with poor mask fit. So you're like, gosh, that's kind of, if the bag's going to deflate, I need the bag inflated. But y'all, this is an alarm. I don't know if this is built in or it's by the physics alone, but this is an innate alarm. If your bag is deflating, we think back to NRP. We're thinking, all right, well, we're going to do some Mr. Sopa here, right? I don't have a great seal with this bag, or if the patient's intubated or something like that, what else might be going on? So it does deflate with poor mass fit, but that is your number one alarm to say that you can do better. FiO2 can be adjusted and can provide free flow oxygen. A lot of the times you're going to use these with a blender, especially the NICU and things like that. I usually always had a blender somewhere, and you can set your FiO2 whatever you want it to be. Now, if your bag is so sensitive that the actual pressurization against the neonate or the pediatric, the actual pressurization is what is keeping it functional, you have to imagine that the differences or your return, like I like to say, from your patient is more easily felt because it's going to recoil back into that bag. Unlike your standardized kind of hard plastic self-inflating, this is more malleable bag. Just think of it kind of as as an anesthesia bag. You've seen some of those folks with an anesthesia bag, big green balloon looking bag. Think of it as that, and how the the actual pressurization causes it to function. Of course, your airway resistance and things like that should be felt much easier. And with this, the same can be said with your fine control of tidal volume. We can squeeze the bag more. Let's say the bag is the tidal volume, I don't know, of 100. Then if you squeeze that whole bag and it's going to deflate completely, you know that you've given 100 or very, very close to it. When we squeeze a full self-inflating bag, we can't like crinkle it up or anything without probably destroying the device. So we can't really say, let's say if an adult's 600, we can't say we're giving them 600 or what have you. But cool thing about flow inflating is it can be used as CPAP as well. So again, you can kind of set your PEEP, set your peak pressures for also another alarm system, and use it as CPAP, which is quite handy. Now, and I say this every time. Now, this picture makes the self-inflating look like it's like the flow inflating is Richard Pryor and the right one's Arnold Schwarzenegger or something. This is a flow inflating bag with all the bells and whistles on it. The ones that I was used to using, you had to go find a PEEP valve. We kept them in the crash cart or whatever, but you had to pretty much manually put all this stuff together. And it was kind of a hassle sometimes, but you got the patient at 18 a PEEP or whatever we're going to do. But the flow inflating kind of has all this stuff built in. We see our flow control valve. A lot of them have a pressure release valve. You can set some of those. You can set a peak pressure, and they're quite impressive, honestly. And I feel like kind of like with the simple mask, right? We stopped using them because they weren't being used correctly. I think we would run into the same problem using a flow inflating bag, especially in our ERs and things like that. But I definitely think they are a great addition to any type of code, cart, anything like that. Look at our intubation equipment. Cuff pressures can be monitored via posy cuffulator or manual pressure manometer. I've never used a manual pressure manometer. Maybe some of you all have. I've always used a posy cuffulator. We tried, or I have tried to use the AG, the cuff feel or what have you down here. And I'm just not a huge fan of them. I'm not like completely sure how accurate they are. I never really ran a posy up against it, but I get the idea. But I'm sure they're probably more expensive too. Your ROI is probably decrease on that. I don't know. But yeah, you should check these Q8. Now, we used to do vent checks Q2. I'd always just, check a posy at least Q2, Q4, just because I'm there, right? You may as well. It takes 2 seconds. But at least every 8 hours, I would say no less than once per shift. Should not exceed roughly 20, 30 centimeters water. These values change sometimes too. You can say 20, 30, 25 to 35. And it also depends on if you're using TOR or our units here. So usually when we're seeing pressures greater than 30, we're losing the integrity of our cuff, right? Something's going on with the cuff. Maybe there was some swelling upon intubation, and you used a smaller cuff or smaller cuff, and you're having to put tons and tons of pressure in there. That could definitely be a cause of it. Maybe there's some tracheomalacia going on, loss of cartilaginous tissue, what have you. Something's going on, and you're more than likely going to want to try to, at least if you're not the one to change it, bring it to the attention of the physician or whoever's seeing that patient for a possible tube change. If it reads 0, of course, just like anything we've ever learned, if it's reading 0, it's probably a leak somewhere, right? Or, then check your connections. If there's no readily available means of measuring cuff pressure, so, in COVID, they were like, don't use our posy cuffulators, bro. We can't keep buying those. Use a minimal occlusion, minimal leak, however you want to say it. You inject air into the cuff until no leak is heard. withdraw just enough air to hear a slight leak at peak inspiration. There is, I would say it's kind of controversial. Do it only if you have to, because there has been known to be aspiration and things like that. Boy, COVID showed us that. Let's look at intubation equipment a little bit more. So the pediatric patients that must use cuff tubes. The cuff should be a low pressure, high volume, what I've always called like a floppy cuff. That way you can pump up the volume and it still, create a situation low pressure on the tracheal mucosa. So with these, you kind of don't want to get your cuff pressures greater than 20, because specifically with these kids, you can do long-term damage over a short amount of time. So high cuff pressures with a consistent leak indicates that the tube is too small, or if we're thinking about epiglottitis and things like that, we may intubate with a smaller tube. Eventually, say if the patient keeps needing intubation for some other reason, that swelling goes away. You keep pushing air in there and air in there and air in there, and you keep getting a consistent leak. You need to change that tube. But yeah, too, again, just kind of like we were talking about with the MPAs, if the tube is too small, there can also be increased airway resistance, which could create I guess, an artifact type of waveform. You think, oh gosh, this kid's got these crazy peak pressures. If the tube is too large, then it can be decreased perfusion to the tracheal wall, just like there would be if you're having if there's losing integrity of the cuff and you keep pumping it up. Necrosis and stenosis. It's hard to gauge the air leak, vocal cord and glottic damage. And I mean, these things can be lifelong and very detrimental to these children. So we're looking at blade tubes and suction catheters based off age. Now, earlier we were talking about less than 28 weeks, so on and so forth. So we're starting with 6 months and going up. Generally, you can say a lot of us are used to, if we work with, let's say I'd have to say there's a few more in the adult population than the children. Most of us are used to 7s, right? So greater 12 and greater, you're probably going to use regular cuffed ET tubes with them. And as you go 6.56, 5.5, you're probably still going to run into the cuff, but at lower than that, you're going to run into the uncuff. So we take our tube size, we take our age in years. Again, this is just a kind of a quick estimate. Our age in years plus 16, divide that by 4. That should give you roughly about what type of tube size that you're going to use. Let's look at intubation itself. So uncuffed ET tubes, generally used for children less than equal to 8 years old, due to the anatomical differences that we talked about earlier, being more anterior, more narrow, so on. Reasons for intubations have been mentioned. So we want to facilitate, protect, and with this, we'll throw in the addition of administering medications such as epinephrine and the like. Nasal intubation may be performed and follows the same procedure with a couple minor changes. The tube is passed through the nares, nasopharynx, until it is visualized into the pharynx. You are taking the gill forceps at this point, which are curved forceps, into the mouth, grab the tube and try to pretty much move that tube into place. I've never performed nasal intubation, nasal tracheal intubation. It is quite medieval looking, though. I've sit in on a few of those. So how we want to intubate, right? We'll try to pre-oxygenate for age. Again, we want to watch out for things such as retinopathy, nitrogen washout, things like that. Roughly 2 to 5 minutes, really, if we can. We want to recommend meds such as sedatives and other paralytics during this time. We'll place the child in the sniffing position. Make sure not to hyperextend the neck of neonates and infants, as it can cause some massive damage. And secondarily, is you're just going to flop that tongue straight in your way anyway. Look at the Miller blade. It's best for the neonates, kind of as we mentioned earlier, the way the epiglottis lays. Lift the blade to visualize intubation landmarks. We cannot rock, and I mean, they drill this into our head, right? So, I've watched a few doctors, crack some teeth out and stuff like that. You weigh the risk versus the benefits, right? But think of these children that don't even, maybe don't even have all their teeth or no teeth at all, and we're sitting there, rocking on their gums. That can cause lifelong damage to a brand new life. I mean, hopefully, what we're doing in intubating these children is to hopefully grant them, 80, 90 years or more of living, good living. And, just by that alone, if we don't do it properly, could diminish that. So, of course, we want to insert the appropriately sized tube, the type of tube, however one cuffed or uncuffed. Again, those uncuffed tubes generally have a glottic marker for depth. Cuff tubes insert until the cuffs pass through the vocal cords, inflating. See what you've got. Secure the tube, however it may be. A lot of the kiddos get tape. A lot of other folks will have ET tube. OG tubes may be indicated for overdistension. So let's see here. A 4-year-old patient is undergoing intubation due to epiglottitis, and the attending asks the respiratory therapist what size, type, and ET tube and blade should they use. What should the RT suggest? So they're 4 years old, and they have probably terrible upper airway swelling. So hopefully this is in the OR when I type this out. Right. So in epiglottitis, you want to do OR intubation. So we're probably not going to use a 7 cuffed, and we're probably not going to use a 6.5 uncuffed. Those are, you just pretty much throw those out the door, right? But then we have a 5 uncuffed and a 5 cuffed. Right now, we kind of said that less than equal to about 8 years old, we want to consider that uncuffed tube. And a MAC 3 for this just would it match the patient? Again, clinically, sure, maybe we do need a MAC 3, but with this, we're going to say that the answer is B, a 5.0 uncuffed with a Miller blade too. We're probably not going to use a Macintosh in question D. Immediately after intubation, we want to assess tube placement. Right. I'm sure probably many of us or most of us have set for RRT, right? And the big thing with that is verbiage. So assess tube placement. Observe chest rise. Look at SpO2, color change, heart rate. That's a big thing with neonates, right? Effective ventilation. We'll look for a heart rate, very, very responsive to ventilation. I always say ventilate, ventilate, ventilate. Unless heart rate's less than 60, right? Then we start CPR and consider intubation. We'll also take the chest and abdomen. Let's see if we've got any type of air going into the stomach. Make sure we've got bilateral equal breath sound, so on. Check for condensation inside the tube, right? Could very well be an indicator. We can use capnography, CO2 detectors. We'll look at our colorimetric CO2 detectors. They'll change at about, at about 5% exhale CO2. I was kind of always taught you take that 5% and multiply it by 7. You've got 35 mils PCO2. So that kind of tells you that you're at least approaching normality or some type of homeostasis. These do depend heavily on perfusion. One of the big indicators for this, if you're not doing CPR adequately, your capnography is going to be whack. If you're not perfusion nothing, you're not going to have really any carbon dioxide being made or anything like that. Thinking of cardiac arrest. We'll read inaccurately if there's an air leak or perfusion is decreased, and it should make sense if you're doing like an inline capnography. There's an air leak in there, it's just going to wash out that CO2 by diffusion. And there's side stream and inline, and there are perks and caveats to both of those. We'll read inaccurately if there's esophageal intubation. There could be, you got to think, folks, it's really the hydrogen ion secondary to CO2 crossing the blood-brain barrier. CO2 can't cross the blood-brain barrier, hydrogen does. But it's really that is causing, acidity per se. So if have hydrochloric acid in our stomach, maybe we drink a Coca-Cola or something before we coat it. I don't know. It can read inaccurately in that manner. So think if I accidentally intubate the esophagus and the child drank a soda or something just before the accident, it could definitely read inaccurately. So I say, again, we're looking at MPS exam or RT exam. It's the verbiage, right? Don't get switched up on this. So the chest x-ray is what confirms depth and placement. I repeat, confirms depth and placement. Boom, right? So, we can literally see this, our radio opaque line right here. We can clearly see that's right. It's fairly easy to tell there. Now we're looking. This is just to confirm depth and placement, right? You can see probably end of our ET tubes there. Right? That's why those X-rays are so important. That's why half the time, by the time you get done inflating the cuff, X-rays already there at the door. Look at tube exchangers. These are anytime, if I could, anytime I was intubating, I would always intubate with the bougie first. Just because it's just much easier to use. It's much easier to get that smaller guide, I guess, kind of just like a guide wire. It's much easier to get that through the glottic opening than it is an ET tube for me. And then once you get it placed, you have your tube exchanger. You just slip your ET tube right up and over it. Of course, hold this thing in place for the love of God. In some instances, you can't pass it through. You have to take the whole ET tube out, start anew. But these are for me, these are the way to go for initial intubation. So we've got a pediatric patient who's just been intubated and placed on a vent. What should the RT recommend to confirm tube placement and depth? Look at a colorimetric CO2 detector. That's great. That'll probably tell us that it might be in there. Look at a centimeter marking on the ET tube. It's a pretty good indicator. If we're running high, then we're probably right main stem intubation. Should we get an X-ray? Return volume on a ventilator? Sure, that'd be fine too. But no, the answer is X-ray, right? All of those are great assessments and great objective things, but we want an X-ray. Why should we suction our patients? Well, sometimes that is the sole reason for intubation, right? We'll keep a patent airway. Maybe we want to stimulate a cough. Maybe we're doing some apnea testing or brain death testing, something like that. Stimulate a cough. Specimen collection. Indication for suction is increased secretions, airway obstruction, weak or absent cough, and swallowing difficulties. 33%, if I'm not mistaken, 33% of patients that aspirate develop ARDS. So swallowing difficulty and managing that is pretty important. There are a number of hazards. So the most common is trauma. We know that we don't want to stay in the airway very long. We want to hyperoxygenate, right? So most common is trauma. We can cause a lot of trauma, especially when you're thinking about a trach. Think about your ET tube ballard, right? Think about your inline suction. Now place that same ballard on a trach. You're going to suction their toenails out, right? So be cognizant of that if you are dealing with trachs and ET tubes at the same time. So yeah, hypoxemia, we're literally sucking the oxygen straight out. infection, especially if you're using open suction. Atelectasis is, again, the same reason for hypoxemia. Vagal stimulation, and if this happens to you, boy, you'll know it. It's a scary situation, especially if they don't return back to baseline quick enough. It can cause bronchospasm, of course. Anything, if you're banging around the breathing tubes down area, you're going to cause some type of bronchospasm, right? Or very well could be an accidental extubation, believe it or not. With trachs, one of the most common reasons for accidental decannulation is trach care, right? So suction's right up there with it. Of course, we can suction oral, nasal, or artificial route. I'm sure as RTs we could figure out some other way to do it too. Procedure for OT-NT suction for really any type of suction. Pre-oxygenate. If you're going to go any of those routes, nasal is going to be the easiest. Advanced only during inhalation. Try to lubricate, especially with NT suction. We'll try to lubricate the catheter. Again, remember for NT suction, we look at things like conal atresia and septal deviation and stuff. But generally, we want to try to keep the, I guess, the bevel or the distal end of the catheter towards close to the septum. If for kids, remember suction the mouth before the nose, right? Always thinking ABC, right? A, B, C, D, E, F, G, H, I, J, K, L, M, N, M before N, mouth before nose. And that is because, let's say they're obligate mouth breathers. So let's say we suction the nose and stimulate them to take a breath, and their mouth is still full of, amniotic fluid and what have you. They just sucked every bit of that straight down into their lungs. We don't want to do that. Catheter size for this. We take the inner diameter of the tube, divide that by 2, and multiply that by 3. Again, you want to, I was kind of always taught you take your tube size times 2 with the next size down from that. Again, these are just really quick guesstimations. Make sure to be appropriate with this patient population. ET tube, trach procedure. Pre-oxygenate maintained during the entire procedure. Again, we want to watch out for retinopathy. So for infants, we generally want to do 10 to 20% more of what they were on. Aside from, if we're thinking of straight neonates, I guess, aside from a CPR or general pulmonary need, we don't do 100%. We do 21, 30, 31, 30, 30%. Again with the blender. So children would do 100% for at least 1 to 2 minutes. Again, we can hyperoxygenate. We'd like to do at least 5 minutes, but sometimes we know it's not possible. Look at vacuum pressures. Adjusted with the tube occluded for neonates, we'll do 60 to 80, negative 60 to 80 mils of merc, and peds 80 to 100. If we're thinking about, maybe, let's turn the suction pressure up, this, that, and the other, I would reserve that to be one of the, if you're at 100 for peds or 80 at neonates, I would kind of reserve that and try to troubleshoot other options because suction pressure a lot of times is what's causing all this extra damage. If no suction, just like everything else, you better check for a leak. Big thing there too is it's, check your canisters. Sometimes a lot of folks want to change their canisters. If it's full, it ain't going to give you nothing. So we'll look at the types of catheters and suction devices. Of course, we've got our standard catheter, right? Then we have our inline Ballard, which is kind of, I won't say it was invented for, but it's really contributed to a decrease in ventilator-acquired pneumonia. And that's really because we're not having to break the circuit every time we suction the patient. Coude catheter, I've seen this with like a mini bronch, where doc will be like, hey, I need to get a sample from the left lung. And you're like, I mean, it's a blind bronch, but Coude catheter is essentially designed to try and help you get that left main stem sample. Bulb syringe, especially for neonates, and remember, in before in. And do not, so squeeze the bulb syringe before you place it into the nose or the mouth, not after. Meconium aspirator. Now with NRP, there's an ongoing debate of whether do we repeatedly intubate and suction meconium and things like that. So kind of the consensus is with that right now. Even if the baby is meconium stained, we do not do anything unless there's respiratory distress or known meconium within the airway. And we know that can cause a ball valve mechanism within the child, which would probably present pretty quickly with distress. But we can use the meconium aspirator. It is connected to the end of the ET tube. And of course, we have our sputum trap or our Lukens container. So with our inline suction, thinking about VAP, we don't have to remove the patient from the ventilator, reduces VAP. We don't stay no longer 10 seconds in the airway, no longer than 5 seconds with suction. Turn the patient's head slightly to the right may help anatomically speaking to present with a more bilateral, safe bilateral sample. But especially with the Coude catheter, because it is going to try to pull that left. If hazard occurs, to decrease the suction or suction time. Biggest thing, any type of infection, right, is hand washing. Make note of that. We do oral care, especially when I worked at an LTAC, or what do they call it, a critical recovery facility. Oral care was huge. Ask any dental person, they'll tell you how important oral hygiene is to lung health. You keep the head of the bed elevated 30 to 45 degrees. This is also super great for GERD in patients that have a lot of acid reflux. We do gentle suction. Don't automatically crank it up to, what does it go up to, like 360 or something. Don't crank it to 360 and just leave it so you can get them suctioned and get out. We can use an MDI instead of a small volume nebulizer, and this is essentially decreasing any type of humidity or condensation. Subglottic and reuse as well through the small volume nebulizer, opening, closing, and all that stuff. We use a CAS system or subglottic secretion removal tube for continuous aspiration of subglottic secretions. And this is big especially for extubation. You can put a -20 of suction on there and just, as you're about to start suction or extubating and things, which we left it on pretty much continuous. But it definitely helps with having to gag them to death with that young coward. But generally, as soon as we intubate somebody, we want to be thinking ways to get them off. So minimize intubation time and vent days. So we will do frequent spontaneous breathing trials and non-invasive positive pressure ventilation when we're able to. Now, we don't want to go from straight extubation straight to BiPAP. Always take this as we're going to try BiPAP and keep you off the vent as much as possible. We can use heated wire circuits and condensation drains. We know that Pseudomonas loves warm, moist areas, right? I don't know about for you guys, it always smelled like Cocoa Pebbles to me. Tracheostomies. Yo, folks, these tracheostomies are just little baby ET tubes, right? Inserted through a surgical site. I've seen some bad ET tubes, and I've seen some bad surgical sites, right? But generally, these are a much more secure airway. Eventually, the patient hopefully is able to eat and speak and kind of carry on fairly normal, I guess. You can use a home vent with these trachs. There is less airway resistance than an ET tube, and it decreases our dead space by half. Complications from this, of course, if it's surgically or even percutaneously, we're going to have bleeding. Could have pneumos, subcutaneous emphysema, air embolisms, accidental decannulations. And folks, if you have accidental decannulation very shortly after the trach has been placed, that stoma site can suck back up, and you would turn around and try to find the trach, turn back around, and your stoma's gone. But later on, of course, we're going to look at infection, especially when we're looking at surgical sites and things like that. Hemorrhage. So I've had this, I've been a part of 3 ruptured innominate tracheoinnominate arteries, and it is an absolute bloodbath. One of the things you can kind of notice with these patients, and it is hard to notice, especially going through our day-to-day motions, is that when the cuff is inflated, it is resting against that tracheoinnominate artery, or that portion of the tracheal mucosa. And it essentially just rubs it until it ruptures. And when it does, there's, unless you're already in surgery or something, there's not a whole lot you can do with it. Of course, obstruction. As these patients start to recover, and their secretions at first will be generally tremendous, the blood and all that. Yeah, obstruction is definitely a big thing. You can cause a tracheoesophageal fistula, just like we could a tracheoinnominate fistula. And of course, accidental decannulation. I thought this was just a neat picture, nothing really, I won't say nothing to gain from it, but we can see pretty consistently, we have our thyroid cartilage or our cricoid cartilage, but we look at one signet ring down, so 2, 3, 4 is very common placement for trachs. I just thought it was a pretty neat picture. I never really kind of thought of that when I was doing all kinds of trach care and everything like that. There's a couple of different kinds. I never really used a whole lot of fenestrated trachs. Most of the time we would just go for, generalized trach, posy, cap, and then decannulation. But fenestrated is good for weaning. Tracheal buttons, essentially, they just retain the stoma. Most commonly used, what I've always used is a generalized Shiley or something like that with a or speaking valve, most commonly a passive mirror valve. One-way valve. Take a breath, they exhale, it closes, forcing air through the vocal cords. And with this, and as a very new RT, of course, all of us at one point, the first time I ever ran across a posy thing here, I was like, oh yeah, definitely, I remember this from school, no big deal. Yeah, I can go put this patient on their speaking valve. So I go into the patient's room and I take them off the ventilator, cut the ventilator off, put them on a trach collar or whatever, and pop that passive mirror valve on. It was the sheer panic that came across the patient's face was, it was immediate. But yeah, the biggest thing to remember with this, and the main thing I remember from it from that point on, is deflate the cuff. They'll let you know about it really quick. Now we're thinking about neonates and pediatric populations, or rather the child population. Maybe the need for a passive mirror valve is not immediate, but you have 8, 9, 10 years old pediatric patients that have trachs. Of course, you're going to have speech involved and things like that. So kind of like I said with trachs, the most common cause of not the most common cause, but a very large contributor to accidental decannulation is trachea itself. And I mean, if you think, we have our trach ties and everything, and we do have to change the trach ties. The biggest thing to remember here is to always hold on to the flange, or the flat piece that the ties are connected to. Make sure you always hold that in place the best you can. You may cost the patient to death, but as long as they have a airway, you're good to go. So the entire trach should be changed once a week after tracheostomy by the physician that placed the airway, and then routinely every 1 to 2 weeks. So kind of the way that we did it, if it was a fresh trach, the doctor would change it. After a little bit, 2 weeks, couple weeks, whatever, me and another RT would do it. But anything after that, we would pop them in, pop them out like it was nothing. We'd have patients that would do it for themselves, which was always great. But if we have a disposable inner cannula, simply just toss it out and replace it with a new one. You want to do that minimum twice a shift. Sometimes you'll do it 4, 5, 6 times a shift. These new trachs. Number one thing I always said, and number one thing I always tell my students about this portion is you never throw that inner cannula away until you know you have the right size, the right type, and it's going to fit. Because a lot of those, some of the new ones coming out now have that 15 mil adapter built in, but a lot of them, especially with the disposable inner cannula, that is your 15 mil adapter. If you throw it away and the patient, is on a vent, something like that, high, pressure control, something like that, you're SOL, right? You're gonna have, what are you gonna? You can't. I mean, you could, but you have to dig it out of the trash can. That's gonna be a whole mess right there. So never ever ever throw that thing away unless you have one that you know is going to fit. Clean the stoma, or replace the gauze, another form of skin barriers. We use, I think it was Tegaderm or something like that for big trach wounds, but most of the time you're going to have your standardized 4x4 split gauze. Clean the stoma site and the neck as well as any other exposed hardware at least twice a shift. And here's the thing, folks, you get a terrible trach for the first probably week, you're going to be doing a lot of cleaning of that trach. But after that, as long as you keep it up, after that, it's kind of like, you do your laundry as it comes. You do your dishes as it'll just stay clean, which is beneficial to you and for the patient. Change the trach ties as needed. So kind of as I said, less than a week old, then the doc's going to do it. Don't care who you are, where you're at. If it's greater than a week, but it's still right around 2 weeks, that 2 RTs can do it. But greater than 2 weeks, and you should be golden. Gather all the same stuff you would for intubation, right? And the thing is, sometimes if you can't, for instance, I've had situations where you can't get the trach back in. You can use, for instance, a 6 ET tube because it is just essentially a small ET tube anyway. But the thing here is with your trach, you're going to have an obturator, and this kind of acts as your stylet, although the trach itself is generally pretty rigid. Bovanas and things aren't very rigid. But, so a suction the trach, release the ties, have the patient take a breath, deflate the cuff, and remove it. Sounds pretty standard, right? Insert the new trach a little sideways, and I need to get a video, but a lot of times we don't have time for the videos. You want to insert the trach from the side of the bed and kind of scoop it in and twist as you're pushing through. Once the flange, once you're at the flange, you want to remove the obturator very quickly, or else they won't be able to breathe. Verify placement, tie it back down, and try to get you a what? X-ray. You're at. For extubation, we're going to try to meet our standard criteria, right? We want our spontaneous RSBI, things like that, to be within line. We want to pass whatever your protocol is for however long you need to pass your SPT and things like that. Of course, check your electrolytes and all those things before extubation. Have everything you need to reintubate or recannulate the patient. Suction above and below the cuff. Don't forget above the cuff, or else you're probably going to be a case of pneumonia that the hospital's going to eat. Pay close attention to nasal drainage, things like that, especially with the kiddos, right? My kid is sick right now, and she will not blow her nose for the love of God. Will just will not blow her nose for nothing. So keep that in mind. All that drainage has got to go somewhere. Remove the securement device, deflate the cuff, remove the tube at peak inhalation. Don't tell the patient to cough and then remove the tube. Big deep breath, pull the tube, and cough. It's kind of like, you know, a 1 and a 2 and a 3. However, some patients are still a little more sedated than others, but give them some O2s if they need it. Give them some humidity. Biggest thing you want to look out for is stridor and respiratory decline, right? Stridor is kind of somewhat to be expected. So you'd say mild stridor, we're going to use maybe some humidity. We'll give you some oxygen, maybe steroid or something, steroid. Moderate O2 cool mist, racemic epi, steroids, heliox possibly. Market stridor and respiratory distress, you're probably going to have to reintubate them. Biggest thing about unplanned extubations and decannulations is securement devices. You know, patient wiggles down, is able to get a hold of something, pulls it all out, right? And this kind of comes again, improperly secured airways, misplaced CT tubes, lack of adequate sedation, restraints, and other procedures. One of the things is if it is a new airway and an ET tube, PT or somebody's trying to go in there and do something, just, you know, if you have time, just go in there and assist. You know, maintain your airway. It is yours. Have all the same safety equipment that you're going to need for intubations, and be ready because especially with PT and you know, mobilizing on vents and stuff, your rates of extubation might go up just by the nature alone. If the trach becomes dislodged, occlude the stoma site and try to start bagging the patient. If you can't, nothing's going to happen. They have some weird upper airway anatomy stuff going on. Go ahead and place that ET tube. Difficult airways, you're usually going to use some kind of flexible fiber optic intubation, probably bronchoscope or something like that to try to get the airway in. But if you cannot, life and death situation, you can do emergency cric. Those are eventful situations. Biggest thing right there is because you're not going to be doing the cric, be ready to assist the physician via the laryngoscope blade or any other type of tool that they may need. Look at this as no more than 3 attempts at intubation. They try to start thinking, all right, I think I'm going to have to cric this patient. Retrograde intubation, cricothyroidotomy, and emergency trach require a physician. Just be ready. It's all kind of the same tools you've been accustomed to, besides the scalpel and those little clamps down there, but physicians should know about that. So what's the conclusion here? Neonates and pediatrics are very different, right? Well, than adults anyway. The same can be said about artificial airways. There are many different flavors of these devices. Intubation requires a plethora of gadgets and a large amount of knowledge. Self-inflating bags, limited FiO2, but it does always refill. Flow inflating bags, we have consistent FiO2, but it requires a gas source. But it can be used as a CPAP. An immediate assessment is needed post-extubation, but the X-ray wet confirms, yeah. When we're looking at suction, it shouldn't be limited, but it should be finessed. Again, folks, we are the suction folks, right? We are the booger getters. That's what we do. We should be able to finesse. We shouldn't be causing any damage doing this procedure. Ventilator acquired pneumonia, prevention is critical, and we've got protocols in place. Most places have protocols in place to keep this from happening. It is a team effort, however. Trachs ain't that scary, right? I was terrified of the things at first when I was a little new grad, but anymore I'm like, when are they getting trached? They are much more secure and easier to manage, if you ask me. Extubations can be planned or unplanned, but you should plan for them. Always be ready for them. Difficult airways are a thing, and there are tools to help us, unless you got to cric them or do retrograde intubation. then you're there to help the physician. It's been great. It's been fun, like always. Keith and everybody, Respiratory Associates, it's always a pleasure being here. Appreciate you. Definitely stay tuned for the Flim Fighter game show. It's kind of unique. He's going to let you pick. So stay tuned for that. Got a cool little question coming up, and hand it back to Keith. Thanks, everybody.